My name is Cano. I'm currently taking nursing research, Nursing 307. And for my evidence-based practice research project, I chose to look at post-surgical outcomes of total joint arthroplasty with interventions for psychological comorbidities. The National Institute of Health predicts that from 2015 to 2050, the global population of those 80 and older is expected to triple. And as we are caring for an increase in geriatric patients, we're going to need to look at what kind of conditions and diagnosis they normally have. A very common diagnosis for many older people is osteoarthritis. The Osteoarthritis Action Alliance states that 88% of people experiencing osteoarthritis are 45 years and older. And currently an estimated 242 million people worldwide have symptomatic OA that affects sleep quality, mood, and physical functionality. As the older population rises, the number of those experiencing a musculoskeletal disorder that affects them on a daily basis is going to rise, and OA is just one example of that. Additionally, OA is the third most rapidly rising condition associated with disability behind diabetes and dementia. So although patients will have multiple reasons for getting a total joint arthroplasty, I chose to look more specifically at osteoarthritis within my own research because it is such a prevalent condition, and it does lead to increased disability risks. OA limits a person's ability to manage other conditions like diabetes, hypertension, and a third of osteoarthritis patients have 5 or more chronic conditions that they're currently trying to manage. Not only is osteoarthritis extremely prevalent and associated with increased mortality, it is extremely expensive. On average, a person with OA will spend an additional $11,000 each year trying to manage their condition, and over $71 billion per year has been estimated as an indirect cost, such as from lost earnings from people that are not able to work. As a percentage of older people within the world's population increases, osteoarthritis of the hip and knee is becoming one of the most frequently occurring musculoskeletal disorders and the leading cause of pain and disability. This graph from the NIH is a depiction of the estimated increase in patients that have been diagnosed with OA by 2040. And these are just patients with osteoarthritis. This does not include other musculoskeletal disorders that could lead to a total joint arthroplasty. So this is just one part of the population that we can take conclusions from this research and apply it to them as well. So there looks like about 54 million people in around 2014. And that number is estimated to increase to 78 million people by just 2040. So looking at the clinical problem, arthritis is currently the leading cause of disability in North America, and many people are looking to total hip arthroplasties or total knee arthroplasties or other total joint arthroplasties after more conservative treatments fail. A THA, a total hip arthroplasty, and a TKA, the total knee arthroplasty, are really cost-effective surgical options for patients with severe or end-stage musculoskeletal disorders that have truly lost a lot of their function. And it's been shown to be a definitive treatment that can allow patients to return to pre-disease function. A subset of patients within those receiving total joint arthroplasties have psychological symptoms, and those patients have been found to have suboptimal postoperative results. within the categories of pain, physical functioning, quality of life, and subjective satisfaction. About 1/4 of patients experience intense or prolonged pain, mobility restriction, and a reduced reported quality of life postoperatively. Additionally, psychological symptoms negatively influence motivation, energy, and coping skills of patients. And a lack of motivation, energy, and coping skills has been correlated as an important factor of influence on patient-reported outcomes following a total joint arthroplasty. Those experiencing a psychological disorder before surgery, or those that are pain catastrophizing, which is essentially having an anxiety reaction associated with the pain that you're anticipating, these patients have been related to high pain scores, disability, longer hospital stays, increased depression, higher use of opiates, and increased complications. The influence of this pain catastrophizing, the anxiety, the depression on post-operative total joint arthroplasties is really poorly understood. There has been research to implicate a correlation, but there's not a definitive answer of what causes these patients that have some kind of psychological diagnosis, a psychological need, to do poorer than those that do not. So enhanced recovery pathways, or ERPs, are commonly employed with arthroplasties to improve the quality of care and reduce the length of stay in the hospital. ERPs include a multidisciplinary approach that holistically includes the entire patient in all spheres, including psychologically. Therefore, it is relevant to the health outcomes of many to study how preoperative psychological factors influence people. So the PICO question that I chose to research in lieu of this clinical problem was, among patients with a psychological comorbidity of anxiety or depression, do interventions to address their psychological comorbidity positively affect recovery outcomes in total joint arthroplasties? Within this PICO question, we can break it down. The population is patients with a psychological diagnosis receiving a total joint arthroplasty, specifically related to osteoarthritis, just because that is the extent of where research lies currently, because it is the most common musculoskeletal disorder and such a big factor that leads to disability. For the intervention, it is a psychological intervention, such as medication, counseling, or use of an ERP, all post-operatively. We are comparing patients receiving a total joint arthroplasty, specifically related to osteoarthritis without a psychological diagnosis, to those that do have one. And the outcome is having a normalized return to physical functionality and recovery time. As an example, 2 to 3 months for a knee replacement and 1 to 2 months for a hip replacement. So with these interventions, are these patients receiving the same results that they would have if they did not have a psychological disorder that might make their recovery harder? So in order to find relevant research for this PICO question, I decided to target specific peer-reviewed journals and articles that gather research on nursing of the elderly, joint replacement surgeries and recovery, and management of depression in the elderly. Additionally, looking at institutional policies of how clients are determined to be candidates for major surgeries despite possible psychological problems, and discharge teaching for those patients. I utilized a number of different databases such as PubMed Central, Medline, CINAHL, and when looking for terms to look for these kinds, the kind of research that I was hoping to find, I had a number of search terms that I tried to use. within different spaces and different databases, such as management of depression during major surgery, discharge guidelines after joint replacement, enhanced recovery pathways in depression, enhanced recovery pathways in anxiety, preoperative depression and outcomes of TKA or THA, and pain catastrophizing and total joint arthroplasty. When just using terms such as total joint arthroplasty, I was receiving too much information, hundreds and hundreds of articles that weren't especially relevant to the specificity of this PICO question, and so I had to incorporate other terms into my search, such as looking specifically at psychological disorders and this type of surgery, as well as the kind of recovery that these patients were utilizing. So my findings and the clinical significance of the studies that I looked at, multiple studies found reliability in their results when utilizing similar scales to indicate physical functionality, quality of life standards, and incidences of pain. Within the 5 articles that I utilized in my research, 3 of them used the Oxford Hip Scale and the Oxford Knee Scales, which is a 100-point scale with a variety of questions that a patient self-answers to determine the amount of disability that they are having from the problem with their hip or the problem with their knee that is leading to the need for a total joint arthroplasty. The greater the number on the scale, the higher the disability. Additionally, the hip disability osteoarthritis outcome score and the knee injury and osteoarthritis outcome score were utilized by 3 of my sources. And this is a similar kind of scale that gives you a level of disability a patient is experiencing. However, it is conducted by a nurse during the assessment. That is a mix of a physical assessment with looking at subjective questions that a patient answers. So there was a self-reported scale as well as a assessment that a nurse was doing. And there was also common standardization in answers and questions of patient responses while they were answering questions about their outcomes. And this occurred within 4 of my articles. Additionally, multiple studies. These studies were taken from multiple places around the world. One of them was from the Netherlands, one was from Indonesia, one is from Canada, one is from the US, and they utilize similar populations, but the places that they took them from, the information and the patients from was very different. For example, there was 3 different cities and 7 different institutions that patient information was collected from in the study from the Netherlands, while the study from the US focused on 1 central learning institution with 1 surgeon that had a high volume of total joint arthroplasties. These studies looked at essentially the same type of patient, somebody over the age of 18 receiving a single first-time total joint arthroplasty related to a primary diagnosis of osteoarthritis and a previous clinical diagnosis of anxiety or depression that was actively being treated by a doctor. A secondary study utilized primary data from evidence-based processes and outcomes of care, EBP5, which is conducted by the clinicaltrials.gov in the US. And this found that patients with anxiety and depression that were actively being treated with medication and psychological interventions indicated levels of greater disability using the OHS and OKS scores and scales before and after their surgery, more so than patients without a clinical diagnosis of anxiety or depression. So their degree of disability was still higher than those that did not have a clinical diagnosis despite the fact that they were using these interventions. The same study found that patients with anxiety or depression reported lower satisfactory outcomes after surgery. However, the difference in the increase of quality standards between the group with anxiety and depression and those without at baseline, it was clinically insignificant. So both of these groups gained the same amount of points on the scale. For example, although the group at a mean would have started at a 50 on the OHS-OKS scale, their disability was reduced by 20 points. While the group without anxiety or depression started with an OHS-OKS score of 30, and their results were also minimized by about 20 points. It was clinically insignificant. Both sets of patients gained nearly the same amount of physical functionality and increases in quality of life after a total joint arthroplasty. The patients with anxiety and depression were just starting at a lower baseline. However, these differences are obviously related to anxiety and depression, and they could also be correlated to age and physical comorbidities. It was noted that those with psychological comorbidity were far more likely to have additional physical comorbidities, such as diabetes, hypertension, obesity, and previous pain in other parts of their body. So the evidence from these studies really indicates that there's a clear correlation between depression and anxiety with increased patient-reported pain, poorer patient-reported outcomes, and the physical comorbidities. However, despite this correlation, these clients really made the same amount of gains that the patients without did. So despite the similarities of the targeted samples and the scales of indication and the differences of the sample population from various parts of the world, whether using multiple or one institution, really the largest gap that wasn't addressed within all this evidence was that those with a psychological comorbidity are still ending their journey of recovery at a greater place of dysfunctionality and disability despite using interventions. This was not identified as being due to greater incidences of physical comorbidity, psychological problems. It could be a dichotomy of both. There's not clear research on that yet. So these studies have indicated that with ERPs and interventions in place, patients with a psychological comorbidity have the ability to make nearly the same amount of gains as those that do not. But now research really needs to be conducted to determine how patients at a lower baseline due to those psychological comorbidities can reach those higher scores of recovery and that increased level of functionality as those without. So a total of 5 research articles were analyzed in regards to this PICO question. And without these interventions, it appears that clients with a psychological comorbidity would not have found the same amount of positive gains as those without anxiety or depression or another psychological comorbidity. But as stated, there needs to be further research to be conducted to confirm whether this is due to a prevalence of increased physical comorbidities or a dichotomy of both. So in terms of the relevance to clinical practice, nurses are responsible for holistic care of their patients, and we should be committed to addressing all the spheres of a patient, including the mental health, in order to affect their overall quality of life. Patients with mental health problems should be identified and receive specialized care for their psychological interventions, no matter what other kind of care they are receiving. This kind of research really tells us that all nurses, no matter your specialty, really need to be a psych nurse in one way or another, because the outcomes of their patients may be determined by other spheres in their lives, and it's very important that we address all of those. Thank you so much for listening to my presentation, and it was a real joy this semester to be able to research this.